We'll move on to our next speaker. So our next speaker is Professor Sean Bagshaw from University of Alberta, Canada, and he will talk about interaction between AKI and delirium.
Good morning. It's a pleasure to be here. I'm going to speak for the next 15 minutes about the interactions between AKI and delirium in our ICUs, which I believe is something that probably hasn't been well investigated, but is actually a fairly common issue and a common problem. So many of you have seen this figure before, many meetings in critical care. I'm not sure if it's been shown here, but this is the study, the brain ICU study, that's looking at long-term cognitive function after critical illness. And these global cognitive scores at 12 months among survivors really show that 34% of survivors actually had cognitive scores that were analogous to having mild traumatic brain injury. And 24% actually had scores that were analogous to having mild dementia associated with Alzheimer's disease. And these were heavily correlated with having had delirium and the duration of delirium during critical illness. This is a population-based study done in my home province of Alberta, Canada. And it really showed that delirium was fairly common in our ICUs, but not only that, it actually showed that delirium was associated with early readmissions to hospital, representations to emergency and early readmission to hospital, and death over the long term. So it's probably important for us to recognize that, of course, AKI is not an isolated phenomenon. We've actually described and there's been many meetings dedicated to this, the interactions between the heart and the kidney, the lung and the kidney, the liver and the kidney. But there's probably been less attention paid to the actual interactions between the brain and the kidney. And I think there's both direct and indirect effects that could be quite important for us to appreciate in our critically ill patients. So there's not a lot of literature, at least experimental literature, that's looked at this, but this is one elegant study that I wanted to highlight for you. So this was an experimental study looking at mice who underwent 60 minutes of ischemia reperfusion injury, and then it looked basically at their brains 24 hours later. So you can see going from left to right, basically what you see here is increased systemic and brain-specific pro-inflammatory mediators, right? The second slide really shows that there's an increase in glial fibrillary acid protein deposition in astrocytes in the brain, in those that had AKI versus not. And in the third slide, it looks at there's an increased extravasation of Evans blue dye in the brain. This would be an indirect suggestion that there is a leaky blood-brain barrier. And then finally, and I wasn't aware of this, but is an open field test looking at function of mice. But basically, these mice were impaired. They had impaired motor function as a consequence of this AKI insult and the effects that it had on the brain. So trying to put that together into cartoon for you, we have AKI. It induces a systemic inflammatory response to some extent. That has widespread effects in the blood. It spreads throughout all organ systems, but it has a direct effect perhaps on the blood-brain barrier. It makes it leaky, pro-inflammatory mediators cross, and then they interact with the microglials, the astrocytes and whatnot, and certainly in susceptible patients in the ICU, of which we have many with multimorbidity and age and other factors, these patients go on to get delirium. So what is the pathophysiology then in humans? I think it's really complex. It's quite multifactorial. There's probably direct and indirect pathways. There's systemic and neurospecific inflammation that occurs in critical illness and maybe with acute kidney injury. And there's a lot of biologic processes here that may be at play, right? Imbalances in neurotransmitters, accumulation of neurotoxins, nitrogenous waste accumulation in AKI, so uremic guanidinal compounds that, suppress GABA or activate NMDA receptors, causing excitation states, predisposing to delirium, etc. Not to mention all the care we provide to patients with medications and whatnot, and then all the other sort of adverse effects that can occur with AKI. So a quick search of the literature doesn't find a lot of studies that have tried to look at this, but there's some common themes that seem to arise when you look at them. One, delirium is common in patients with AKI, right? And whether there's a true causal mechanism to that or not, we haven't really proven in humans, and that might be difficult to some extent. There seems to be a gradient increase in the severity of AKI and the degree, either the prevalence and or the severity of delirium. And there's probably a lot of confounders that we have across these studies. So some of the concerns would be there's differences in case mix here. There's wide disparities in how we provide angular sedation for our patients. And these studies really don't do justice to what's the baseline cognitive assessment of these patients, to say the least. But let me take you through a couple of these slides. This was the first study by Pezzanti and colleagues, single center academic ICU, 304 patients over the age of 60, really looking for delirium within 48 hours after ICU admission. And they found delirium in 70% of these patients. And I think what's interesting is you can see in the table, these were the factors most independently associated with the development of delirium. And you can see naturally, underlying cognitive impairment and use of benzodiazepines, very common. We hear about that all the time. But look at that. There is a doubling of serum creatinine, or a creatinine greater than 2 milligrams per deciliter, sort of prominent there as one of the risk factors for the development of delirium. And one of the challenges with this study is it wasn't focused on the kidney. So it doesn't discriminate between acute and chronic kidney disease per se. It doesn't look at the temporal relationship between the onset of AKI and the onset of delirium. So there's lots perhaps to learn, but here's an early signal going back to 2007 saying there may be an association there that we need to appreciate. Perhaps the best study that looked at this was Eddie Sue and a secondary analysis of the brain ICU study. And I suspect he probably presented that study here many, many years ago. But this was 466 patients at the Vanderbilt site specifically. They looked at the exposure being AKI, and really they wanted to know the association between AKI and the change in daily mental status using CAM-ICU and the RASS scores for levels of sedation. And what they showed that AKI was common, 65%, delirium was common, 75%, and delirium and coma was occurring in approximately 47% overall. So they had 5,000 days of observation for these patients, and delirium occurred in about 32% of days and coma in 14.6% of days. And I think what was interesting is that AKI was present in 37% of days when mental status was normal in these patients. However, on days when patients were delirious, AKI rates were 50% and 65% when they were comatose. So there's definitely some associative data here. And what they also looked at was the probability of normal mental status relative versus coma delirium by AKI severity. And these figures are small, and I apologize for that. But what they really show on the bottom is KDIGO score and probability of mental status change. And the bottom line is, as your AKI score went up, when you had stage 1, 2, and 3, you saw a decrease in normal and an increase in the proportion that became delirious. Now, what's really fascinating to me is that this table over here shows that amongst that 10% that received renal replacement therapy, perhaps there was some attenuation in the degree of delirium that was there. So this is some very indirect and highly confounded data that suggests in selected patients, perhaps judicious and or strategic renal replacement therapy could mitigate the incidence of delirium. This is another study, about 1,000 patients, of which 42% developed AKI, and they're looking at the outcome of delirium. And really, you can see across the board here, delirium really common amongst patients with AKI, about 60%. The delirium, and the challenge here is that delirium was predominantly, like more than half was hypoactive for the most part. But here's a table showing the independent association between stage 2-3 AKI and the development of delirium in patients with AKI. This is also correlated with prolonged or longer lengths of stay than if you did not have AKI. So what's interesting here is this is another small study, single center retrospective of patients who had been mechanically ventilated for 7 days. And the main exposure was fluid overload, defined by 10%, a greater than 10% in total fluid overload. And the main endpoint was suggesting that fluid overload as a state was also significantly associated with increased risks for development of delirium versus not being fluid overloaded. Now, another interesting study that was published in the last couple of years, this is a secondary analysis of the AKI-2 trial. So just to recap, the AKI-2 trial was looking at 2 strategies for initiation of renal replacement therapy: a delayed strategy, which really aligned with the delayed strategy in the original AKI trial, versus a more delayed strategy, which was a longer watch and wait sort of phenomenon. And what they've done here is this, and the main study didn't show any sort of difference in the primary endpoint of renal replacement therapy free days, but there was some concerning hazard for increased mortality amongst those in the more delayed strategy. But this is a subgroup of those patients who had coma at baseline, and really looking at the differences between these two strategies and whether there was a transition from coma to awakening at 28 days, a difference between the two strategies. So this is just a table summarizing some of the key features, but I think it's worth pointing out most were vented, most were on vasopressors, high SOFA scores, so they were pretty sick with multi-organ dysfunction. And you can see there's clearly some differences in the serum urea values at the time that patients were enrolled in the trial and randomized. What they really showed was that the probability of being awake according to the renal replacement therapy strategy, i.e. delayed versus more delayed, was different. So the transition intensity was lower if you were in the more delayed strategy. You were more likely to remain comatose for a longer period of time. And they looked at a number of different sort of strategies to apply this. And basically they found across all these states, the probability of being awakened and the next day after these neurologic states was obviously lower with the more delayed strategy. So I was interested to know, given this, that there's a little bit of literature out there that suggested that, AKI may be an important modifier or risk for development of delirium. I went to the PADIS guidelines to ask, what does it say about risk factors for delirium in ICU patients? And so these non-modifiable risk factors were identified, not surprisingly, older age, dementia, prior coma, pre-ICU emergency surgery, high acuity of illness and or preoperative, risk prediction scores. Modifiable risks were benzodiazepines and blood transfusions. So nowhere in the guidelines does it actually mention any association with acute kidney injury and how you might need to mitigate or, alter your therapies and thinking related to that, given what you have with your patients. That being said, there are 2 clinical risk prediction scores for delirium that have been published in the literature. And what's fascinating to me is that both of these actually include a variable that looks at kidney function to some extent. So increasing serum urea would be one of the predictors within these 2 clinical risk prediction scores for delirium occurring in the ICU, at ICU admission or within 24 hours. So it's clearly there. It's sort of percolating to some extent that, AKI and or, loss of kidney function may be an important factor we need to consider. How do we intervene? I think most of it at this point is going to be harm avoidance. I don't think there's been any interventional trials related that's looked at this, but avoiding deliriogenic drugs, of course, toxic metabolites and drug accumulation is clearly going to be a problem in critical care. Angulosedation strategies as well. Again, harm avoidance. Avoid those medications like midazolam that have active metabolites that can persist forever in patients that have acute kidney injury, and recognizing the metabolites of other common drugs we give. Even though we don't think they need to be renally cleared to some extent or renally dosed, some of their metabolites may accumulate with time and contribute, again, to delirium amongst those with AKI. I think fundamentally as well, as part of our interprofessional and multidisciplinary teams, we enlist the expertise of critical care pharmacists, and I think that would help going a long way. And lastly, what's the role of renal replacement therapy? I have to say there's a little bit of indirect data that comes from the brain ICU study and comes from AKI 2, but it's uncertain at this point. Theoretically, sure, renal replacement therapy could clear neurotoxic medications if they're renally clearable. Along with toxic metabolites and uremic compounds. That may have some bearing, and there's some indirect evidence from the AKI 2 trial to suggest that. So I'm not sure where we'll be with that. So that's it. Thanks.
Excellent. Very good. Questions indeed. Any questions from the floor? I can imagine, as you already told us, that it's really difficult to decipher association and causation, and if it's just clearance of sedatives and stuff like that. What would be your proposal actually to move forward to find out what's happening?
I think it would be of interest to do some prospective observational cohort work where maybe you're actually collecting a lot of detailed information around exposures, and maybe you're doing some other biomarker assessments, and maybe you're doing some even brain imaging or EEG or other things to try to understand in patients with AKI versus non-AKI, and maybe give us some insights into, the attributable potential hazard of that.
Yeah.
I think that would be a start. I'm not sure, we're ready for interventions to try to mitigate this association at this point, but I think we probably need some baseline work to do that.
Yeah.
A great talk, Sean. So my question is, assessing renal function in critically ill patients to say whether they have AKI or not. If they have a rise in serum creatinine, it's clear. But because many of these drugs that are being used are based on EGFR creatinine-based equations, they grossly underestimate renal dysfunction. So I recently had a patient who came in with, septic shock secondary to cellulitis, and we started cefepime per guidance of 2 grams Q8, which is the current recommended dose. And she was fine. Her mental status was fine. The second day, she was completely confused. And a creatinine was 1.0, and we checked her cefepime level, it was 86. So there is all these, and there's some evidence that cystatin C-based equations might help with, dosing of these things. But the question is, how do you estimate renal function in some of these patients, especially if they have subclinical AKI?
Yeah, that's a great question. And that's a good example of a drug that's clearly neurotoxic. So, I think the challenge for us is you can't simply adopt a EGFR equation for patients who have unstable, creatinine and urea values that they come in. And I do get calls or recommendations through Epic from the pharmacists in the basement sometimes that say, oh, well, this EGFR is really good here. You guys should probably up your dose of this antimicrobial. And I'm like, well, no, actually, they're not making any urine, and the creatinine is actually doubled, even though the EGFR formula says that, it's normal. So I think you're right. I think what you're getting at, to some extent, there's probably some education piece there. There's probably the importance of awareness. There's probably the importance of a multidisciplinary team with insights into that's looking into it. How do you measure kidney function in the ICU? I think this is the 30th meeting. We've probably been asking those questions. And there's certainly new sort of innovations that are coming downstream. But, measuring creatinine once a day is probably not a good start if you don't have any other mechanisms to understand what's happening to the kidney. So, we could have a whole conversation about how to measure kidney function to dose drugs in the ICU.
Nice talk, Sean. Particularly in older folk, when you get osmotic shifts, particularly if you've got a higher sodium or a lower sodium and the urea is pretty high. I know you guys are really gentle and you like to bring it down slowly with CRRT. But what about just the osmotic shifts causing the confusion? I know I've seen it many times, been asked to see someone. Sometimes they're, sodium's a little high and they put them on a standard CRRT prescription. They don't adjust it for the sodium, and the next day the person's off the planet. Now, whether that was due to some other cause, but you've got to wonder about the sodium and sodium profiling and things like that.
Look, I think you're right. I think if you go back and you read in detail the renal trial, even in the high-intensity arm of the renal trial, there was some disequilibrium syndrome. So there's no doubt in my mind that CRRT is not immune to causing rapid osmolar shifts, particularly in potentially vulnerable populations. So that would be like your heart failure, your cirrhotics that come in with sodiums that are low to begin with, 125, 126. And if you just simply put up a 140 bath, or you worry because they're acidotic and you augment that with bicarbonate, which is highly, highly osmolar, as you know, hyperosmolar, you can shift sodiums pretty quickly. And so those are things that I think that's a practice awareness, concern and education around that. But I concur with you 100% that probably occurs even in CRT when we think we're being gentle in the wrong susceptible patients.
I'd suggest it might be nice to have a little...
We have to move on, I'm sorry.
Yep.
Yeah, thank you very much indeed, Sean.